That's the same for you, Gerardin, right?
Yeah, that's the same for you. It's a shame, isn't it? Because you want to go cool off, and then the water is hypothermically cold.
Right. So just to inform you, our YouTube channel is now live, and will be visible now from anywhere. And hopefully we can share this widely also to colleagues who are unable to, as I was saying earlier, we were unable to share the link this past week for some reason, but hopefully we will address these challenges going forward. Could we just confirm that Dr. Samson Kiware has been able to join? Samson, have you been able to join? If any of my colleagues from Dar es Salaam is able to help with that, kindly do that. Or if Samson, if you're joining with someone else's computer, you can just turn on your video as well and let us know. So we can have you online, and that's the only wait we have, and then we'll get going. So I would like to introduce again our guests today. First, we have Professor Samir Bhatt. We have Professor Lucy Tusting. Lucy's last name is Tusting, right? Tusting. And then we have Professor Gerardin, and Professor Samson Kiware. And as usual, myself and Dr. Sheila Ogoma, we are hosting the masterclass. It's a conversation. You're welcome to share your questions via the chat box. And because we have a number of experts in the room as well, we request that you continue with the conversation as always. We will try to elevate as many questions as possible to the experts and keep it that way. We are starting in 10 seconds. So I just want to check what that chat message is. Good afternoon. Good afternoon. I'm waiting for confirmation from anybody in Dar es Salaam if they are aware whether Samson has been able to join. Could someone please just send me a chat message? Everyone else, we ask you to kindly mute your microphones. Kindly mute your microphones. Please mute your microphone or we will remove you from the class. Dear colleagues, again, last apology for the delay. I think we should start now. To begin with, I'm just wondering whether any of our experts have any questions to us just before we continue. Samir, do you have any question? Lucy? Yalin? Samson, are you there?
I think Sheila answered all of our questions in the lead up.
We've mailed Samson the Zoom link, so hopefully he'll be able to join soon.
Fantastic.
If we know Samson, he'll be able to pick up wherever we are. Excellent.
I just noticed that someone whom we admire a lot from Ifakara has just joined the call. His name is Peter Masharia. He's a great young man from Kenya. Peter, welcome to this class, and we hope that you will help us a lot as well in the conversation. And that actually brings me to the start. Samir, do you speak Swahili?
Kidogo bwana.
Habari yako. So this makes for a very good introduction because you're, I mean, it's nice to know that you're from a malaria endemic country as well, even though you write mostly from Europe or something like that. But Sheila and myself would like to begin by a very, very general question to all of you. And this is in general term, and any of you can answer this actually. how useful are these maps? And of course, here we use an example from Malaria Atlas program. But you could talk about any of these maps. How useful are these maps?
I'm happy to go first, considering these are my maps. It's a difficult question, Fedros, because when you try looking at a map like this, in general, I think there was an expectation in the past, as these methods came to prominence, that these maps would answer and be useful in all aspects of malaria epidemiology and policy. And as time has gone by and the methods have become more sophisticated, and more importantly, the data from these countries has become far better, looking at a global map like this plays a very important role in dictating policy from an organization such as the WHO, in monitoring global progress, in advocacy for what needs to be done at a very large scale. And these maps can, to some degree, inform nationally, but are far less reliable for that. And so looking at this map now, it's extremely important from a policy advocacy point of view. It's an extremely important avenue for us to know where we are with the malaria endemicity situation now, how high prevalence is, how things are going down, how this is responding to interventions, as we'll talk. But this map alone does not tell us in Kenya at all, what policy should be dictated. And we need other methods, maybe built from the same frameworks, to zoom in and answer policy relevant questions in that specific context. So
that's an important point to begin, actually, because these maps are very popular. And you were mentioning policy, but if you go to Geneva, WHO people will say we don't make policy. And we just do some guidelines. They say they don't create any policy. So beyond advocacy, really, what do we need to do to make these maps useful beyond advocacy?
I mean, and please, Lucia or Jeline, jump in at any point. From a technical standpoint, part of the problem behind these maps is that they tell us what's happening at a 5-kilometer resolution. And the uncertainty at that 5-kilometer resolution is inherently high. It's inherently uncertain because there isn't a large amount of data. For this map to really inform policy in terms of African governments at a local level, there needs to be more added into this. So number one, there needs to be a trust that the uncertainties are accounted for well. But most crucially, and this is the unanswered question, which we can't do now, and I don't think we have the data to do now, there needs to be causal explanation for why this map is the way it is, to explain as much of the multifaceted landscape of malaria epidemiology and the why. And this why question is the next frontier, and it is one that we cannot tackle yet, but methods need to be developed for. And so when you have all those components together, then you have a reliable explanatory factor to tell someone in, say, Kenya, well, this is what we think that's happening in the Nairobi area, and these are the reasons we think this is happening. Do these gel with your intuitions on the ground?
Right. Thank you very much. Anybody wants to talk a little bit about that as well?
Sam's covered it very nicely, actually, but I think he touched on an important point, which was trust. And I know there was a recent study by Jane Webster and colleagues where they went to NNCPs in 3 countries and asked people how useful are risk maps for your work, on an operational level. And I think one of the really key messages was that people felt they needed to be able to trust the kind of the predictions, and particularly where data points are sparse, that's a really key issue. But as Sam says, that in terms of sort of identifying the higher risk areas that need particular targeting, there are all sorts of uses for these maps at a country level, if people feel able to sort of place their trust in them and to use them to guide their decision making.
Yeah. I mean, I remember being at a meeting in Geneva once, and some of you guys might have been at the same meeting, where a map like this was presented, except it was the blue and green shades were red. And some official from an African country asked, why is my country so red? And yet nobody has come to speak to me about, is this what you're talking about? Lucy?
Yeah, I mean, I think that there is a real need to kind of segue the results from these predictions with experiences at a country level, and to kind of establish what is most useful, and then to provide that kind of data in partnership with country managers and the programs. Sam, do you want to add anything to that?
Yeah, I mean, what I wanted to say was that, you know, when someone comes with these maps, you know, as somebody who's flown around the world, and particularly to a lot of African countries to sort of explain these maps, you know, the questions I get asked more often are, the first one is, you know, why isn't a certain region exactly 10% prevalence when we did a survey last year and we found it to be 10% prevalence, right? And so suddenly they think to themselves, well, this model isn't fitting my data correctly. And this ultimately is the difficulty and a problem on the modeler's end for not communicating what statistical models are meant to do and where their limitations lie. So that's the first thing. And then the second thing is not synergizing all the various sources of data that are available. All countries have access to DHS data because it's freely available, but not all countries have the expertise to build special models on it. Whereas,
thank you. I think, go ahead. Yeah. So I think you guys have introduced some very key points here: the question of trust, the question of capacity, the question of aligning this to local evidence, the question of advocacy and need for improvements. Someone has put on the chat questions of scale. And of course, in this class, the class is titled Maps and Models, but we will talk much more than just maps today, about much more than just maps today. But just as indicative topics, you've seen all this in the advertisements, and I hope, you know, we can all enjoy this together. So to proceed, I would like to go to Lucy. And Lucy, when people present malaria maps, they have a choice of what indicators to use. The map that we were showing earlier uses Plasmodium falciparum parasite rates. There are many other indicators. They are not all relevant in certain spaces. One thing that you've done, which we found really cool when Sheila and myself were preparing for the masterclass, was some great assessment of the usefulness of these indicators. And you looked at a number of them. I think you looked at 5 or so of these indicators. Could you just talk to us about the usefulness of each of these indicators and where and when we need to use them? In brief.
Sure. I mean, so as you say, there are different ways of measuring malaria transmission intensity and burden of disease. And those range from the variables that are sort of closest to the intervention themselves, and those that are more downstream or upstream, further away. The gold standard for measuring malaria transmission we would consider to be EIR, so the entomological inoculation rate, and this is the number of infectious bites per person per year. And this is a very direct measure of transmission. Sam, I think, is better placed to comment on what mapping exercises have been done for the different metrics. I'm not quite sure what's been done for EIR. But then we have various other metrics that we can use. So for example, parasite rate is parasite prevalence, and that's probably the most commonly used metric that is mapped. I think because of the availability of data, it's very widely recorded. So yeah, I won't go into any more detail than that, but Sam, do you want to touch on some of the mapping?
Before Sam goes on, I mean, in this paper, Lucy, you have this statement, we highlighted that in yellow here, that when assessing specific, sorry guys, I have to kind of admit guys as well, when assessing specific interventions, that people might choose different metrics depending on the settings. What does this tell us when we want to compare maps? We have these global maps that are done based on parasite prevalence rates. And in this paper, you seem to be saying that, there might be different applications for certain metrics and all that. How do we create that alignment? Should we have maps for everything, or is PFPR, for example, considered universal, that it can be used throughout?
I think it's a really good point. And we, I think a lot of this actually comes down to what would we ideally like and what can we actually achieve, because in reality, creating global maps based on some of these metrics would be very difficult due to the lack of data points. But certainly, parasite prevalence does have its limitations. As you get to very, very low levels of prevalence, it becomes far less responsive to changes in transmission and the effective interventions, so maybe less informative. Sam, do you want to add anything?
Yeah, and please, Fredros, to stop me if I stray into any of the further topics there is a bit of an issue. There's a bit of an issue here in that so prevalence is very useful, but then prevalence as a metric itself is inherently linked to sample size, right? When you go into a low endemicity setting, you need to sample thousands, hundreds of thousands of individuals just to find one or two cases, right? In a very low elimination setting, in which case prevalence is always going to be a terrible metric because it saturates at either end and works quite well in the middle, somewhere around the 20 to 50% range. And so the issue is that all of these individual metrics have their pros and cons. And the difficulty from a method side is how to synthesize them. EIR is the gold standard, but there isn't much data on EIR. So how do we take small amounts of data on EIR and merge them with large amounts of data on prevalence, with routine case reporting on incidence, and put these all together while reconciling the data limitations? And so really it's not a question of one versus the other, but how do we reconcile all of them to give the consistent message? Because it's the same infection process. These are all just summaries of a mechanism.
Right. We notice also that there's an additional layer of complexity, which is with the parasite prevalence rates, there's also the age factor. So in most of your maps, you do age 2 to 10 for some reason, I guess, because of the plateauing. But, this is not always what people have in the surveys. No,
and it is a big limitation, I think, to focus on 2 to 10 rather than modeling the age distribution and seeing how that varies country by country. The age distribution is also slightly wrong because especially when you go down to mortality, I think Prabhat Jha has shown, that you do end up with this spike in mortality as individuals get older, as one would expect, that tends to just be ignored when we look at these parasite prevalence maps.
Thank you, guys. Let's not belabor this a lot. Let's leave it there. I'm going to hand over to Sheila to continue the conversation. Sheila, please.
Yeah, thank you, Fred. So, Lucy, how do these epi and entomological indicators change across the malaria continuum from control all the way to elimination and reintroduction? Just briefly.
So yes, and you're talking about different metrics of transmission.
Yes.
So as we go from very, very high endemicity down to very low levels and then through to elimination, the different metrics have different levels of precision and accuracy. So that might inform what we would like to use in different settings. So for example, with EIR at very low levels of endemicity, it becomes very imprecise. So it's not terribly useful in those settings always, and we may look to a different metric to use. Is there anything sort of in particular you want me to touch more on?
Yeah, so for instance, I think maybe using an example. So for instance, if a country a program wanted to evaluate the impact of, say, a vector control intervention, whether it has an impact on transmission, say in a pre-elimination setting, which are some of the indicators or parameters they should be looking at, both AP and ENTO?
Well, I think there are certain indicators that are sort of always useful across the board. So we would always want to know parasite prevalence, ideally some measure of incidence of clinical malaria for the epidemiological outcomes. And then for ENTO outcomes, You know, if it's possible to measure EIR, then great. But if not, then there are other metrics like human biting rate tends to be pretty useful from high to low endemicity, especially when you're sort of trying to evaluate the immediate effects of particular interventions on mosquito densities. I'm just trying to rack my brains of other metrics. You know, the serology that we can use to understand immunity, which also gives us a picture over time in terms of changes in transmission. That's reflected in the serology. So I think really you need a range of different metrics in order to build up a picture. And of course, your sampling framework is also very important. So you need to be sampling enough people or households in the right places in order to get sort of accurate understanding of transmission.
Yeah, thank you, Lucy. Fred, do you have anything to add there?
No, I don't. Sheila, you can continue.
Yeah, so I think you guys have touched on this a bit and on how we can use the maps and models in malaria programs or in research. But maybe just briefly again, Samir, I know there have been some answers in the chat box on how best we can use them. Apart from this that we have listed here, are there any other additional uses of maps and models, Samir?
Yeah, I mean, I think that the bullet point that we just touched on before is an important one, right? The models especially, the key behind the models is to fill in the data gaps that we don't know, right? If we were working in a high income setting with universal healthcare like Denmark, you don't need a whole lot of sophisticated modeling to know what prevalence or incidence is because you have a ubiquitous healthcare system that measures everyone, right? The benefit of models is that they can do evidence synthesis. So yes, they can do hypothesis generation. Yes, they can generate counterfactuals and scenarios to inform policy. But the most important point of models, which I think sits atop of all of these, is that they synthesize data to extract signal from noise, right? And this is ultimately what most statistical machine learning should be doing is to extract the underlying signal of malaria infection from all these data measured as a proxy.
Sam, you might want to clarify that there's multiple different kinds of models.
That's right.
That
yeah.
I would not say my kind of model's main purpose is to do that, for example.
Talk to us more about that, Gerardin.
Yeah, so, you know, I think the discussion so far has really focused on statistical geospatial models, which is you know, very focused on the present, on the past, on inferring kind of data, what's going on in places where there's no data. And so I think that as Sam said, the utility of those models will hopefully diminish over time as the quality and abundance of data grows and grows and grows. I mean, I think that they will always continue to be useful because I think that they've been useful in COVID and things like that, even in places where there's more data. But I think the application is going to change and the way people think about them is probably going to change. The other kind of model, the mathematical model, is coming from a different perspective. And I think the real strength of the mathematical model is really in, you know, dreaming about the future and thinking, you know, what would happen if we did this, if we did that, if we combined these interventions, if we made up a new intervention that has never actually been developed or it's in the pipeline and we applied it in a new place, starting from first principles based on what we know about mosquitoes, what we know about disease, what would happen if we tried these different things. And so that's something that is perhaps a little bit more challenging to come out of the statistical model because it's kind of more relying on having data there. But in the mathematical model, because we're starting from a different place, we are more free to play with these kind of hypotheticals and think about what could happen.
I think if you permit me, Tedros, to add one small point there, which is, you know, if we were talking about physics here, then we would have physical models of reality that are extremely precise, right? I mean, down to, with quantum electrodynamics, down to, you know, machine precision levels of accuracy. The problem with epidemiology fundamentally is that these mechanisms are so confounded. And so you have two continuums of the purely statistical models on the machine learning side, and you have the purely mechanistic models, maybe even down to individual-based stimulations on the other side. And finding that happy medium in between. So what Jalene says, I'm just reiterating, is completely correct, is that the different aspects of these models that come together, right? And where you sit on this continuum affects what you're using these models for. If you're doing individual-based mechanistic type models, the best of these is that because you have so many fine knobs to turn, you can create scenarios that are rich and detailed, which you can't do in a statistical model. The more statistical models that try to have some mechanism tend to be better at evidence synthesis. And so there really is a continuum,
Yeah, which I guess also depends on what you wish to do with your model, right? So it's the purpose determines the type of model that you want. A quick announcement here. My colleague Sheda tells me that apparently Zoom isn't working in Tanzania at the moment. I don't know how much information we have around that. So Samson isn't joined yet, but we are hopeful that they're going to do that. Yalin, before we go to the next session, I just want to check whether you have any more to say about what we would add on this list if we were doing a purely statistical model rather than a different kind of model other than geostatistical model.
This list meaning what
like
the
other applications.
Thanks for putting me on the spot like this.
Well, you can also come back to it at a later point, but if you have anything you can add right now.
I was actually thinking early on in the discussion of when you put up the large continent-wide PFPR map, that one of the really great things that that these maps do is to provide a essentially beautiful visualization of what is going on, or for this map, what the model thinks is going on in the country. And I think, even if a country is collecting, lots of data, health facility data, PFPR data, just being able to put that data onto something that I think is, very human brain friendly in terms of visualization, I think is actually just the real value point. Like, say this were not putting, geospatial modeled PFPR on the map, but rather putting, DHS PFPR on the map like that. I think that's still very useful. And I think that having this huge influx of geospatial talent and work coming in has led to maybe, I don't know, maybe some like a blossoming of like visualization that is really pushing people to think more in this space. And I think that's just I hope a really helpful thing for programs and operational folks.
Yeah. No, thank you guys so much. I would like us to proceed to again, we're going to start with Samir here. Actually, Sheila, if you don't mind, I would like to request that you start with status on this one.
Yeah, thank you.
Samir, this is a very common map. So anyway, Sheila, go forward.
Yeah, it's a very common map. A lot of us have referenced it. This specific study is a very common study. So before we get into the details of what the data and the modeling looks like, could you, Samir, just briefly take us through the process of data collection and data combination using the schematic diagram that we have put up?
Yeah, with pleasure. So, I mean, I this is hundreds of people contributed to this work. And it built off the early developments in the Malaria Atlas project by Bob Snow and Simon Hay, putting together, collecting these PFPR surveys, these Plasmodium falciparum surveys. And what they did was they initially collected this data from published literature. They would look at a paper, georeference it. It was extremely painstaking. And I think that the people, Emelda as well, the people who collected this data should be acknowledged wholeheartedly, because they tend to be ignored in lieu of big maps and big modeling. So I must first of all start there. And so that was the first thing, the preparation of the covariance and intervention data. So We had the data coming in, these Plasmodium falciparum surveys, etc. Now, when building this statistical model, we had to get some way to see, well, you've got these prevalences, and they're like a jigsaw, where you've got few pieces on the board, and you're trying to complete the entire picture of the jigsaw. And to complete the entire picture of the jigsaw, you need to sort of develop some mechanism, right? You're saying that, well, falciparum is high in some places because, well, it's green there, and where it's green, there's mosquitoes, or it rains a lot, or it's urban, rural. And so we pulled together these covariates, which are these satellite images. And there's a lot of interesting work going on there, at least in my group now, on this. And then these covariates helped us, fill in the gaps in this picture, right? Now, in a perfect world, malaria prevalence would be completely linked to greenness, and it would be a one covariate linear model with a straight line, and you get a perfect prediction. But of course, we know that malaria is a disease inextricably linked to a large number of conditions, not least poverty, which itself is very complex. And so what we use is this thing called this geostatistical model, a space-time geostatistical model. And the simplest way to explain it is, I'm interested in malaria prevalence, let's say. I know a bunch of factors that drive prevalence, or proxy factors, things like greenness, elevation, urbanicity, accessibility, mobility, all these other things together. But the problem is, I'm not putting into my model nutrition. I'm not putting into my model cultural factors in Mali. I'm not putting any of this into my model. But the data has some structure in it that reflects these factors. And this is what's known in statistics as autocorrelation, or spatial autocorrelation. And so the PR space-time model, which has a complicated name, is just accounting for this rich unknown, these variables that you're agnostic for. And so you account for the factors you do know, and you account for the factors you don't know, but there is still some signal in your data for. And when putting them together, you get something that predicts reasonably well. And so we then predict these maps at 5 kilometer resolution, where each individual map is a realization, a potential, potential situation that could arise, and that reflects our uncertainty. Now, of course, I've ignored a lot of details, and you can see the map in the top corner is reflecting exactly what sort of I was highlighting earlier with Gerardin, which is, how do you put a mechanism in there? For example, there we have a mechanism for starting prevalence, ending prevalence, and how nets work. And this is informed from models, exactly like the kind that Gerardin used. Specifically, we used Swiss Tropical and Dave Smith's models there. But that, in a nutshell, is a summary of what we did. And then the background context was, we all know about this, but most of the world were completely unaware of this public health campaign that happened in Africa between 2000 and 2015, and the billions of dollars that were put in, and the huge governmental efforts from African countries. And so this paper was essentially a summary of that to see the effect of control. And of course, it has many limitations. Yeah.
Before you go to that, we just for the sake of our colleagues on the call, as you know, a big component of these masterclasses is really to explain as simply as possible the technical detail. You starting from very much a climate map, correct?
Yeah, a niche
just
map.
Knowing that, yeah, it's just like this is a Mount Kilimanjaro. At the top, there's definitely no malaria. This is urban areas. Yeah. Okay. And then on the basis of that, you have in the beginning, you have some clinical trial information or some brief surveys of where people have actually collected real data, and you plot those in there and you try to fill in the spaces. Is that accurate way of saying it?
This is an exact representation. Yeah.
Right. But in the beginning, when you guys were still relying on the cartography and all that, from that point, one of the explanations we find from your paper is that a lot of development then took place. For example, improvements in the survey data, improvement in the PFPR measurement methods. Could you explain briefly, before we go to the results, what kind of improvements these were that enabled you guys to then be able to do these large-scale maps?
Well,
what exactly what is it?
The first thing was that the environmental niche was linked to time. These satellites go around the world every 7 days. And so we not only looked at greenness in a given location near Mount Kilimanjaro, for example, we looked at greenness 10, 15 years back in the past, almost a window into how greenness and urbanicity was changing. So this was a huge development because it enabled this concept of time to come in here, that nothing was static. That were the first maps that came out from Simon Hay and Bob Snow and Pete Getting back in the past. Then once you've got these, these factors that are now time dynamic, which is great. Now we move on to that second component that I talked about, these factors that we're agnostic to, that we don't know about, these unobserved effects, right? Now, in a perfect world, we could just put in what's called a Gaussian process or Kriging and run this. Now, the reason that this is so difficult is from a computational viewpoint, it requires a huge number of computations to compute these unobserved effects. Specifically, if I have 100 points, it's 100 cubed computations. Now, if I have 1,000 points, it's 1,000 cubed, and it quickly becomes completely infeasible. And so a large amount of work was done in this from the likes of Dan Simpson, Hovard Rue, Finn Lindgren, where they developed an approximation to this, which is now, the workhorse in lots of geostatistics, of course, the INLA methodology, helped facilitate this. Now, it helped facilitate this not just by allowing us to do Bayesian estimation. In Bayesian estimation, everything is random, so you inherently bake in uncertainty in there. But it also allowed us to compute this in a certain amount of time, and to give people a reference of how difficult this was. Before I started on this project, Pete Getting had an algorithm called which was published in PLOS Comp Bio, which was called the footprint algorithm, that took him nearly a month and a half to fit, whereas the INLA model started fitting in overnight. Now, if you're trying to put in innovative new mechanisms, a month and a half gives you at most 12 tries to try new things. And if something goes wrong, then you're done. And that's a year gone of your life. So I can't overestimate how important this is. And then since this work has come out, I gave recently a keynote lecture on this recently, which I'm happy to give to anyone who's sort of interested on this, on the developments in spatial statistics over the last 10 years. There are some truly remarkable changes now in Gaussian processes.
Right. So we're going to put you on the spot here again because of the way this work has been communicated. And for that reason, I would like to bring in Geraldine and Lucy. You're familiar definitely with this work as well. And some of these processes actually, Lucy, I know that some of these advancements you've also used in some of your own analysis. And Geraldine, even though you haven't worked specifically with this, but some of the ensembles that you guys have worked on have relied on related approaches. So, Geraldine, if you're still there, I can't see you. I think you're there. Could you comment a little bit on how the results of this study have been communicated? From a modeler perspective, do you think that the results of this study are communicated accurately out there by people who are not part of the team? Is Geraldine still with us?
Yeah, I'm still here. I'm thinking about this because these plots we see everywhere. It feels like, half of all slide decks on malaria contain this plot.
Correct. Yeah.
And are they communicated accurately? Well, first of all, these plots are not showing the uncertainty in the prediction. And so that's something that I think all of us really grapple with. If you're already showing a 2D map, how do you then show the third dimension of uncertainty? Secondly, do people even care about it at all? It's not evident that consumers particularly care. Should you put a big warning being like, FYI, we estimate our estimation of PFPR is really plus or minus 20 percentage points. So right. What should you make of these stripes in the first place? And then next, even if this is true on a global scale, it's not necessarily true for your specific context. Just because nets work great in some other area doesn't mean that they work great where you are. And you understand your local context best. So, I think generally people use these plots as a ITN advocacy tool. I don't think that usually it's 2 seconds. ITNs have been responsible for 69% of the decline in malaria since 2000. Next slide, is that enough? Yeah. Is that enough? Sometimes yes, sometimes no. If we want to really think about what is the role of ITN, it's definitely not enough. If we want to go on to talk about other things, like maybe it's okay.
And we're going to come to that actually, but I think it's an important bit of how we communicate results of mathematical models. And so maybe a question to Lucy here is it, could it be that we are misusing, I don't want to use that word, but excessively, are we misinterpreting these results in any way, or miscommunicating it in any way? Like Yalin was saying, you want to extend that?
Well, Fredros, can I turn that question on its head? Can I ask you, what do you think?
I don't know. I mean, I think it's Sami was describing a pretty complex process to generate these estimates. But when you hear people communicate it, it is so oversimplified that, sometimes you're sitting in a meeting with people who spent their lives developing medicines. Child formulations is a fantastic example. When I was born, there were no child formulations for malaria medicines. The people who have spent a lot of time developing this, and they have distributed millions of doses, saved a number of millions of thousands of kids' lives. And then someone turns up with this slide from Samir and says, bed nets have done most of the job. Full stop. And I think sometimes it's oversimplified.
I mean, I think you're right. I think Sam and team would be the first to acknowledge that in order to really understand what's going on here, you have to read the whole paper and think about all of those other factors. But one of the things that is important when you're looking at these is to think about those other variables that have changed in that time period. So particularly thinking about development and urbanization and changes in housing and reductions in poverty, sort of general increases in education, which may be affecting the risk of malaria in other ways. And I think that's what this model probably, it didn't set out to capture that. So it is in no way a criticism of it. It wasn't the aim of this paper, but I think certainly thinking about those things is really interesting and quite useful. So we shouldn't place all of the onerous on bed nets. There's definitely more to it than that.
I'm going to throw this back to. Okay, go ahead, Yalin.
Yeah, I think if you were talking to the child formulation developers, I would not look at these two indicators. I think lives saved would be much better there. Thank
you. Yeah, that's a great point. And I'm going to turn this back to Sheila very, very soon, but very quickly before that, I want to bring this back to you, Samir. And in your paper, you actually made a reference to this subject, what we've just been discussing. And I don't know if we can get a hold of it. The section we've highlighted there in yellow, you kind of warned people a little bit about this misinterpretation. It's important to emphasize that these proportional contributions do not necessarily reflect comparative effectiveness in different intervention strategies, driven primarily by how early and at what scale the different interventions are deployed. Are you and your team, how do you feel sometimes when you see people misinterpret this result? I mean, or is this something you're comfortable with?
Yeah, I mean, no, I'm not comfortable with it. I mean, like, I think there are lots of problems with it. I'll be the first to. I'm not one of those people who will go and defend a piece of work. Science is meant to be inherently wrong and it's meant to be improved incrementally, right? This map here that you show in Figure A is wrong in many aspects and is right in some. The devil's in the details here. I think explaining this figure and the nuances of this figure requires a document probably of its own, right? Some of the points have been brought up, but other ones, for example, you can see that the black line, for example, and this tends to be missed quite a lot, is reducing without any of the interventions anyway. And these are reflecting large amounts of the changes that have happened over time. For example, the work that Lucy and I, and you actually, Fedros, did on housing, for example, would be baked in here to some degree. Now, that point that you've highlighted, I think it really is important to state, because nets had such a huge impact because people invested in nets, right? We first established that nets work and has been shown to work by randomized control trials. Nets are cheap, and nets were thrown in large quantities, right? And as a result, nets had a huge impact, right? There's a density dependence here compared to, say, residual spraying, which is in much fewer countries, for example. And so this point tends to be mixed here, and I think because there's so much advocacy about ITNs, this figure gets put up there. And I don't necessarily disagree with that, because I still do believe that the evidence does point towards ITNs having a large impact on reduction of malaria transmission. Does this mean we can get the job done with ITNs? Everyone agrees no. And anyone advocating that way is perhaps misleading. There is no silver bullet. If nets could have done it, they would have done it. We just had a paper out with Amelia about distribution of nets and showed that there is saturation of who gets a net anyway, which means even if you kept throwing in billions and billions of nets, you'd start missing people, as inevitably you would. There is no silver bullet in here. Nets have their part. Nets have had their impact 2015. Do we want to continue doing this for the next 50 years? Absolutely not. And I think that while this was important to show what can be achieved, this isn't a guideline to what should be done in the future, but rather a starting point that we can reduce malaria transmission, but it gets harder and harder and more complex, and we need diverse tools to get the job done.
Thank you. Thank you very much. Back to you, Sheila.
Yeah, thanks, Fred. There's a question in the chat about the use of PFPR during modeling and mapping. Perhaps, Samir, you could briefly explain how it is used and what's to be considered when using it within models.
Well, sorry, what was the question again? So you want me to explain about modeling and mapping, or?
The use of PFPR as a parameter when modeling and mapping.
I mean, I think we were lucky or rather a consequence of the dire situation that was malaria transmission in 2000, that PFPR was a suitable metric because there was so much malaria around that time. It's no longer the go-to metric for elimination settings. Some recent work that I've done in El Salvador and China, for example, are looking at radically different approaches that use case data, use these stochastic point processes. They're fundamentally different from using the standard prevalence geostatistical models. And I think that this is where investment of time and effort really needs to go into the next generation of these models that are suitable in these elimination settings, where increasingly the data is getting better and better. You don't need a DHS survey. You need DHS surveys, but you don't need to rely on that alone.
Yeah, thank you, Samir. Jalene, would you like to add?
Yeah, I think one big reason to choose PFPR is also the lack of interpretability of routine case data. You know, everyone is collecting routine case data, but the quality is varying. And even if you're, reporting well, collecting well, there's still a lot we don't know about treatment seeking patterns, what cases are dealt with in the community, et cetera. And, maybe if we knew all of those factors, then we could take our routine case data and interpret that and say, like, based on this, we know that there's more malaria in this part of the country and then this, less malaria here. So I think the advantage of PFPR is that it's, I think, straightforward to understand. Like, you did a survey and this fraction of people tested positive, but with the routine case data, you're just like, what does it mean that you had 10 cases in this health facility? Like, I don't know, did you really have 20, but you only wrote down 10? Did you, like, is this, everyone who got sick came to get care here, or is there 90 people who got sick and went elsewhere, or, just medicated at home, or like, so there's no I think easy way to get systematic understanding of routine case data, even like within a district, within a country, and then across countries within a continent or the world. But our hope is that a lot of countries have improved their collection of routine case data to a huge degree over the last decade, and we hope that this, like, very, very important surveillance measure is going to continue to improve, that we increase our understanding of treatment seeking, that more and more cases are going to get quality treatment at a facility or at a point of care that is reporting data well, and so that this data source becomes a more reliable data source, both for country programs to understand what's going on, but also for these kind of global mappers to do their global situation mapping. And I know SAM and MAP are building in this data source into their algorithms now, so that they aren't necessarily relying just on PFPR, which, while wonderful, is also severely limited, but able to take the better temporal resolution of routine case data, better spatial resolution of routine case data, and include that in their framework.
Yeah, thank you. Fred, back to you.
Yeah, we'll keep checking the chat questions as well. Straight answer, yes or no, to Jalin. The PFPR 2 to 10, is this itself a modeled estimate?
Well, this is not my model, but yes, I believe so. Is that right, Sam?
Okay.
I mean, DHS is looking at 0 through 5 primarily, and then your other studies may be looking at different age groups, and the statistical model should be, I think, combining all of the information in a mathematical way to then infer what 2 through 10 would be.
I mean, that's the key thing. The DHS, as Julian said, the DHS is in a relatively similar age range. But yeah, PFPR 2 to 10 is, of course, an adjusted or recalibrated metric, like we recalibrate between microscopy and RDT. And so in that sense, it is modeled, but I don't like to think of it as model. I think it's driven by the data. It's again this extracting signal from noise.
Yeah, I mean, one of the complaints that a disadvantage, rather not a complaint, but one disadvantage people keep pointing out is that you use a model estimate as your key outcome indicator here. So it's kind of multiple layers, but I think that many of these things are improving as we gather more data. And actually, I don't know if Peter Macharia, if you're still on the line, I would like to put you on the spot a little bit, please, if you don't mind. If you could just turn on your video and answer this simple question. You work a lot on improvements of these surveys. Could you just talk to us a little bit about some of the recent improvements on getting high quality survey data that could improve our models in the future? If you're still on the line, Peter. Did I hit blank, or is Dr. Macharia still on the line?
Might be on mute.
Are you on mute, or? Okay, we probably should proceed. If he comes back, he can talk to us a little bit about that. Shall we continue?
Yes, continue, please, Fred.
Okay, so last question on this subject, and then we will proceed. Samir, how would the counterfactual look beyond 2015?
I mean, well, it's a hard.
Have you guys ever thought about it?
Yeah, I mean, we have. I mean, we contributed towards the Lancet Commission on Malaria Elimination.
Yeah, we've got some questions about that.
which I mean, I don't necessarily agree with all of that, but I stand by at least the work we did. I don't know how it will look. It's I think predicting into the future to some degree is in terms of a prediction, not a counterfactual or etc. is a fool's errand to a large degree, because so much changes. One political conflict somewhere, COVID-19 pandemic changes the landscape of everything in such a way that you can't predict this. And this is true for every physical phenomenon. Even like I had my analogy with physics, you can predict the motion of a satellite to Mars perfectly, but if something goes wrong on that path, that's something you can't predict.
Right.
And so I don't know how the map will look moving forward. I know that we need to keep the distribution of nets up, but as we wrote in the Lancet Commission paper, we're not going to achieve what we want to achieve unless we add substantially new tools in large amounts. And I think it's impossible to understate this. We're not going to achieve what we want to achieve unless this is done within country by country people, right? Not, this is the most important facet in all of this, in my opinion.
Yeah, last question to this is, when you do these trends, the concluding statements almost imply causation here, like because of ITNs, ACT, IRS, we had these reductions in cases. In fact, the statement you guys use in your conclusions is that these things led to the reduction of 663 million, is it 1,000 or million cases? Is this really a way to infer causation here, or is it some kind of correlation that is very strong?
Crudely, I think it's fine. I mean, this is not a spurious correlation in terms of looking at births of babies and numbers of storks, right? Something that has not used. We know ACTs, ITNs, and IRS are supported by randomized clinical trials. We know that they have an impact there. We know that there is a direct causal link to malaria endemicity. We also know there's a mechanistic relationship which we've funneled this through. And so this gives us a lot more strength in terms of there is a relation between these two, and we're not just looking at something that's entirely causation. At the same time, we're not accounting for the large number of confounding factors that could probably exist in the same sort of density as nets and endemicity, right? And we're not looking specifically at whether nets are being delivered to places which have high endemicity and that's why they're going down, or no, in terms of how the distribution pattern is working either. So there are a lot in there. So I think to answer your question, frustratingly, it's somewhere in between. It's not one or the other. It's sort of a step on the way to causation, but it's not a direct causal model like you would do using, propensity score matching or double machine learning or something like that.
Right. Thank you. Thank you very much.
But I should add, my colleague Ewan is making steps. Ewan Cameron in MAP is making steps to this, and has a nice new paper using something called the PC algorithm, which is a step in that direction to establish these causal graphs. But ultimately, we know there's an edge between ITNs and malaria. We know that this exists, and it's not spurious.
Thank you. Thank you very much. Sheila, do we have any additional questions on this, or shall we proceed?
Let's proceed, Fred.
Okay. We'll skip this because I think Sami asked already. Sheila, do you still want to tackle this, or shall we skip it?
Let's see. Why was it important to do this analysis?
I think you guys kind of described it.
Yeah, you kind of,
yeah. So, but, Lucy, we're gonna talk to you a little bit about this. Here's a really cool analysis also. I mean, coming from Bob Snow's group. Very simple question here related to the data quality. In this analysis, you see that even before 2000, there were already periods when you had reductions in malaria prevalence. But from 2000, that is much steeper. The other thing that we see there is the residuals on those lines kind of become smaller and smaller. And Lucy, you've done a lot of meta-analysis in recent years with the malaria data as an outcome. And the question we have for you is whether you notice that when you put this data together from historical times, is there improvement? What kinds of improvements do you see in the quality of that data over the years? And what kind of improvements do you think are necessary going forward in this survey data set?
Well, I think probably two things. The first being the quantity of data, because of course, the more data points you have, the better. And certainly since around 2000, there's been this explosion in malaria research, and particularly linking in with that, the demographic and health surveys, malaria indicator surveys. So these are nationally representative cross-sectional surveys done about every 3 to 5 years in different countries. And a lot of those measure malaria infection in children. And I think that's definitely added to the volume of data being collected, which certainly helps. But the other thing, of course, is the way that infection is being measured. And going back to 1900, it was really, spleen rates, which was the really old-fashioned method of measuring infection. Whereas now, of course, we have highly sensitive and specific RDTs, microscopy, ELISA, PCR, all of these very modern methods, which greatly increase the sort of accuracy of the data being collected. And tying in with all of that, I think we have a better understanding of how to sample, how to set up a survey, the numbers required, and where those people should be sampled from. And that's part of the evolution of epidemiology and the methods improving probably since about the 1950s over time.
Yeah,
I think it's important, just if you permit me, Feroz, to note that this historical data, it's an awesome idea, I think, actually, and I enjoyed reading this paper and spoke to Noor about it as well. But I think the problem with the historical data is the volumes of it. I mean, I think there were some issues with the model that they used in terms of the uncertainty at a national level, because the uncertainty is essentially going from 10% to 90%, which is humongous. But that kind of does to indicate to some degree that the data isn't there to make strong assumptions about what was happening historically in the past. At the end of the day, predicting the past can be as difficult as predicting the future, both very challenging. There are extrapolation efforts. Yeah.
Right. Thanks. Michelle, do you want to take any of the chat questions?
Yeah, Fred, there was one question on, let me just find it. There was one question on probably, and it was directed to Samir, and the participant is asking about your thoughts on using IRS and ITN to make predictions and to also show contributions of these interventions to the reduction of prevalences. I think you have addressed it, but for the benefit of our participants, would you like to probably discuss this a bit, Samir?
Yeah, of course. I mean, now the circularity thing is always something you have to be careful of, right? And as long as these end up being independent measurements, I understand they're measured at the same co-located areas. So there's always going to be some degree in there. At the end of the day, you have two entirely separate models for ITNs and prevalence, right? At which point you connect, and then they are obviously connected to a mechanism, which was one of the plots that was showed earlier. And so you connect these together in terms of starting PR, ending PR, and ITNs in there. But they're not sort of confounded like we build a model with ITNs using malaria prevalence and then use that again to predict malaria prevalence. They are independent. That would be circular. That would be using one variable to predict the other variable and then doing it again. That's something we don't do. But there is some degree of circularity in there, and this is nuanced. And what I just discussed with Feroz before, which is, when nets are being distributed, where you're actually performing these measurements, if that is biased all the time, which hopefully with DHS surveys it's not, but if that is biased, you can end up with some spurious inferences.
Yeah, thank you.
It was a very nice question by Alice.
Just adding to something that Sam said. Sam said that he really wanted to emphasize the value of that older data, and I couldn't agree more. I think that if we want to have a full understanding of malaria epidemiology, we have to go back and look at that old literature. You can learn so much from it, and in particular, evaluating interventions. So I think there's a tendency now to rely on very kind of modern designed randomized controlled trials, which are held up as the gold standard for evaluating interventions, but too much focus just on that, and not enough consideration of some of the old programmatic historical data really gives us a much more narrow picture of what works, what might work, what we can learn from the past. I think it's very important to keep that broad perspective.
Yeah, Lucy, on that note, perhaps if you allow me, we could move to some of the questions we have for you, and if Geraldin doesn't mind, we can hold, because we've got quite a lot of questions for Geraldin as well. But you just touched on a point that I think we can segue the correct term here. We'll just pick that up and then we'll proceed with it this way. Some of the pieces, Samir was saying earlier that he supported also the Lancet Commission. And in the Lancet Commission document, of course, you have this divergent views with SAGME and all that. We don't want to go into that. I think there are some great things in there. But one of the things they also mentioned there was that there was already a lot of reduction in malaria cases as a result of socioeconomic development, and that this was going to continue, even if we didn't have any interventions, that these reductions were going to continue. Now, Lucy, in your own work, you have argued that unfortunately the statistical methods of the scientific methods we have today are inadequate to measure the impacts of such interventions. It would be nice if you could talk to us a little bit about this, why you think that we are unable to measure this, especially from historical context, and what we need to do going forward to capture this, such as was argued by the Lancet Commission.
So just to clarify, what we weren't saying that our current existing tools and methods in epidemiology are not sufficient to measure effectiveness of interventions. In this paper, which was published this year, it's quite recent, what we were actually saying is that the way that evidence is pulled together and assessed by decision makers and in setting guidelines at the global level may not be, we may need to think about alternative approaches for some kinds of interventions. So if we think about malaria control, it's not like COVID-19. COVID-19, we need a vaccine and drugs and maybe some social distancing. So it's a very sort of clinical approach to control. For malaria is a disease of the environment and fundamentally is driven by the ecology of the mosquitoes. So I would argue that it's not appropriate to be thinking of it in a purely kind of biomedical way. So if we think about malaria interventions, we can split them into two camps. We've got the biomedical interventions, so these are drugs, vaccines, insecticides, but we also have development interventions, so improvements to housing, better management of the environment, reductions in poverty, better education. All of those factors are really important if we're thinking about driving down transmission, both in the really high endemicity areas and also in elimination settings. And in fact, it's those development interventions which I think will carry us through once elimination has been achieved, and it becomes very difficult to persuade people to sleep under a bed net. So what we said in this paper was that for the development interventions, using a traditional Cochrane review, randomized control trials, you're going to be missing a lot of information about those interventions that gives you a narrow picture and may not lead you to a recommendation at a policy level when actually those interventions could be promoted for all sorts of other reasons.
Go ahead. Did we lose Lucy?
No, I'm still here. I just thought I'd stop talking there and let you say something.
No, I thought we were still talking. Yeah, I thought we were still talking.
I agree entirely. That was a really nice summary. Thanks, Lucy.
Okay. Yeah, Sheila, please.
I think, Fred, we can move on.
Okay. Good. So I think the best way to do that is to continue with the questions from Lucy's side. And Lucy, you and Samir and some other people, maybe myself also, I don't know. I've looked at this one specific speech I would like us to use, but actually before that, there's this other paper that I don't know when this came out. This was 2000, and you can see the date exactly.
It's 2013.
2013, much earlier than that, looking at a clear reduction. So, I mean, China has just been certified malaria free, and a lot of that is just by pulling people out of poverty. So, a very clear sense of this. Based on what you were saying earlier, do you have any specific proposals? Do you have any specific proposals of how this data should be interpreted?
I think what what's helpful to firstly take away. So there's a bit of background noise.
Yeah, I'm trying to mute them. Yeah.
So what we found in this paper, essentially, we did a systematic review and meta-analysis and looked at the relationship between sort of household wealth. So this is, a measure of wealth in the community measured by wealth index or other metrics, and we compared the amount of malaria in children in the wealthiest homes within communities, within villages, with the children who were the poorest. And what we found was that the least poor children had a 50% reduction in malaria risk compared to the poorest. So, and that's within a community. So what we're saying here is there's something to do with relative wealth, which dramatically either reduces or is associated with a reduction in malaria risk. So I think what we can take from that is that we need to understand that a little bit more. And on a sort of global scale, we could hypothesize that some of these reductions in malaria, certainly in places where malaria has been eliminated, Europe, the United States, that reduction was largely in the absence of specific intervention. So it's likely that changes in wealth are contributing to reductions in malaria elsewhere at the moment. And then on a micro scale, sort of within communities, what is it about having more money or more wealth that is potentially protecting you? Is it that you have access to better education? Is it that you're more able to access prevention or treatment for malaria? Are you sleeping in a better house? Are you maybe living closer to the centre of a town or a village where your risk of malaria may be lower, your exposure to vectors may be lower? What is it? And if we can start to understand that, then I think then we can improve or identify potential interventions against malaria.
No, thank you. Thank you.
Yeah, Lucy, perhaps you could take us through how best to interpret the odds ratios, how we interpret, especially using this study as an example. You shared these beautiful slides with us, and we thought that we would take our participants through this as well.
Sure. So in quite a few of the papers that we've published, we've presented something called a forest plot. And you will see forest. Could you maybe go back to the last slide just briefly? Yeah,
can you see?
That's
the forest plot
in the bottom left corner. So this is just a way of presenting data from a meta-analysis. So each row in that forest plot would be one study or one survey, and you're kind of pooling that data together in the meta-analysis. So we just got a few slides to walk you through how to interpret this kind of figure. So Fredros, could you go to the next slide? So if we, so this is a forest plot. So the vertical black line represents an odds ratio of 1. So an odds ratio is a ratio of the odds of an outcome in one group compared to another. So if we're talking about housing, we might say in screened houses, is there a lower or greater odds of malaria than those living in unscreened houses? So we get an odds ratio, which tells you the relative odds in those two groups. So in this forest plot, an odds ratio of 1 means that there is no difference between those two groups. And you can see this first red dot effectively overlaps with 1. The horizontal black line is our confidence intervals. So there is no protection, there's no difference between groups. If we go to the next dot, there is a slight reduction or a shift towards the left, suggesting less malaria in the treatment group. But because the confidence intervals still overlap with that null value of 1, that vertical black line, there's no protection. If we go to the next dot, it's shifted even further and the confidence intervals don't overlap with 1. So we can say that there is significant protection in that group. And then if you go on to the last, so this red dot here at the bottom has shifted to the right. So the odds ratio is greater than 1, there is an increased risk. So this just helps you to kind of interpret those forest plots that you probably see quite a lot of.
You're muted,
sorry, I was muted. Yeah, sorry. I was just saying that thank you very much. That's very, very clear. It helps us understand the forest plots presented in most publications better. Samir, would you like to add something?
Yeah, I just wanted to say that I always found odds ratios very confusing. So if anyone out there always gets confused with odds ratio, I mean, you're not alone, and I'm supposedly a statistician. I always think of the line 1 as even random, just 1 is random. The odds of one event happening versus the other event happening are the same, so it's 1. And then the odds changing either way. And that's the way I always conceptualize it in my mind. So if odds ratios confuse you, that's a good way to start.
Yeah, thank you. Fred?
Okay, thanks. Very quick question to you here. I would like us to relate this to the map we were looking at earlier, which is on the side here. Again, a straight answer from Samir first and then Lucy. Between 2000 and 2015, so Lucy, in your own analysis, the number of Africans living in improved houses doubled, or the proportion of Africans living in improved houses doubled between 2000 and 2015. There are arguments based on some of the studies we've looked at that these socioeconomic developments are having an impact on malaria outcomes. A question to you and Samir, therefore, is, do you think that the counterfactual shown on the 2015 paper accurately reflects the potential impact of these socioeconomic gains?
I mean, at a first straight answer you wanted is no. At a first approximation, but yes at a second one, because as you can see again, that black line in the counterfactual does reduce, and a lot of that reduction can be attributable towards housing. Whether we attribute too much to trends that are collinear between them, perhaps, but I think many of these, the two are not irreconcilable. It's just whether the proportions would change a little bit.
Right, okay. Anything to add, Lucy?
No, just that Sam and I have discussed, whether we could try and measure the effect or the association of these trends in housing, other factors, and look at the relationship with malaria. But so far, I think the conclusion is it's incredibly difficult to do. There's so much circularity in the data. Sam, do you want to add anything?
I mean, I don't know if Fredros will surprise us with our PLOS Med paper further down the line, but essentially, yes, it was, Lucy and I have been, this is a journey where we are thinking about these multi-factor approaches to disease. And, we did look across many diseases at the factors affecting malaria transmission. Housing was clearly one of them, but then so was ITNs. And the effect size were, remarkably similar, but perhaps the scale up slightly different. And so it is a bit complicated to think, because housing has improved a lot, but to what degree these completely improved houses versus just finished houses have an impact is still a little bit unknown. I wouldn't say they're completely unreconcilable, but I would say that, of course, that black line might be further down than we think.
Yeah. I'm just going to go back to focus more on that specific question. Sheila, is this? Go back.
Fredros, if you permit me, there's just also one important point that.
Go ahead, please. Yeah.
On that famous plot that we have of the reduction in time, if you go to that, if you keep going, the one you were just showing before, there is a tendency for us to think that.
You mean the
one after this. Yeah, the counterfactual of
okay.
There is a tendency for us to think that whatever malaria prevalence in 2000 was, that it could not have increased, and I think that this is the fallacy. That the highest it could ever achieve is where it was in 2000, and that prevalence could not go up more. This is a fallacy, and so equivalently, without housing and without childhood nutrition and without all the other tools, such as the medicines of that man or woman that you spoke about before, that black line could have increased over time. And this is conceivable.
Right. No, thanks a lot. Sheila, I'm just going to pull this back to you. Yeah.
Yeah, thanks, Fred. So I think there's a question, an interesting question, Lucy. I don't know if you found out when you were conducting this meta-analysis on housing improvements that there's such a strong effect on housing improvements in the observational studies. I don't know if you found that and if you were able to sort of explain why we see that.
So what we did in this study, and this was then followed up by a second similar study published in 2020, looking at multiple child health outcomes, not just malaria, is we took survey data, so DHS, MIS, and put it into a meta-analysis. So we looked at the association between the odds of malaria infection and the type of housing that the children were living in. And what we found was that across, I think there were about 33 countries that we had data for. Across these countries, there was this consistent reduction in the odds of infection in children living in improved housing. And we can talk about how we defined improved housing separately. So this is observational data. So we can't very easily infer causality from these relationships. But what we can say is that there is a consistent relationship between housing and malaria across the African continent that needs to be looked at further through site-specific studies, experimental studies. So yeah, I think that's all to say.
Yeah, thank you, Lucy. You mentioned there were specific definitions of what house improvement is. Could you please briefly take us through that?
Yes, so in this analysis, we looked simply at the materials used to make the house. So we looked at the material of the roof, wall, and floor. And in the surveys, they are, there's lots of different classifications of these materials, which broadly get lumped into three categories of finished, rudimentary, and natural. Now, this is a limitation of this work, that in order to do this kind of meta-analysis, you have to have a single definition that applies across the board. So that's difficult, but we broadly said that an improved house is one with a finished roof, wall, and floor material. And then in the later work with the mapping work of housing and this later meta-analysis looking at other health outcomes, we expanded that definition also to look at sanitation, water, and density of people in the house.
Yeah, thank you, Lucy. Fred.
Thank you. Thank you so much. I guess I've seen the conversation with Silas and Tim here. I guess for some of us, the question really is, for a policymaker, how do we translate this into action? Is it something that we should, in this analysis, Lucy, one of the things we were figuring out is that this housing is improving without any government intervention. People are just building their own better houses. So someone might say, hey, from the environmental housing perspective, you don't need to do anything, it will just happen. So what people call intervention is something else. I guess the important question is, should this be some kind of an intervention that goes into a strategy as well, or should we just let it happen? It's going to happen on its own. I think that's my last question on this.
Well, Fredros, I'd love to know your thoughts. I know you have a lot of thoughts on this, but just briefly, I would say, yes, this is a fantastic opportunity, not just for malaria, but for multiple aspects of health and well-being, and that if we as a research community can identify those features of housing which are likely to offer protection and encourage those to be incorporated into building regulations, and as you say, most housing improvements are driven by the community, by individuals, but there are instances where there are large-scale housing programs, housing being built, so we can incorporate our recommendations into that to great effect. But I think this also comes back to the old argument about how interventions are delivered, and of course, BedNet's IRS, ACTs, very easy to deliver vertically through external funding. An intervention like housing or environmental management is a lot more messy. It needs to be community-led. It's a horizontally driven approach, and I think that's definitely less appealing to decision makers and funders, and that's a fundamental kind of dichotomy in malaria. I'm sure you have things to say on that.
Fred, you're muted.
Nothing different than what you said. Like Silas, I sometimes think that maybe we should be paying a lot more attention to this other space as well. But I know that it's now possible to get a loan from China to build a kilometer of road for. Can you hear me?
Yes. Yeah,
I was saying I recognize that it's possible to get a loan from the World Bank or China to build a kilometer of a road for $1 million or so. Forgive me for misquoting figures. So sometimes I'm thinking maybe we can get one of these loans to build every poor person a house. Poor here, I mean low income. But some of it could just be these regulations. But I really don't have very concrete thoughts on that. So did you suggest Silas should jump in? Silas, please.
What was the question, Lucy?
Lucy has a question.
You might like to have the floor.
Well, thanks. My comment, I think, is a general one. I was just coming on the issue that you worked on housing, and I think something coming up on environmental management as well. But we really have to recognize that where we're focusing right now on commodities, that is, yes, we do see reduction, nice paper from Samir and team showing impact of nets, but it's showing an impact on nets, but it's not showing, if you had put the same billions of dollars into something else that is not nets, what would you have seen? We don't have that data anyway. And I'd love the modelers to do that. I see Samir nodding. I hope someone would come up with something saying, if you had put the same billions you're putting into nets right now, and into maybe IRS even, into say housing or environmental management or something that is long-term that you don't have to renew every 3 years, what would you have seen? Into education, into, and last point that I didn't write here, sorry if I'm taking too long. There's a general feeling and bashing governments in sub-Saharan Africa for not putting into money, putting money into malaria control and things like that. But if we were looking at the progress into housing, the progress into infrastructure, the progress, if that was interpreted as something that countries are doing to reduce poverty and poverty-related diseases, the picture would be different. It wouldn't be the international community is giving money to Africa and Africa is not doing anything. I think the way we're looking at things now needs to really be more holistic and not just focused on what is being handed out right now. Thanks. Over.
I mean, it's
Thank you,
some great points there. Go ahead. Yeah, Sheila.
Yeah, I mean, I don't want to take too much time, but it's fascinating. Oh, sorry, Sheila. Sorry, you were saying.
No, go ahead, Samir.
Are you sure?
Yes, yes. Go ahead, please.
Yeah, essentially, I just wanted to, because very interesting discussion. We have Silas, and it's very, very nice to speak. But I guess the problem remains, from a modeling aspect, whether this is actually possible or whether people actually doing these models end up essentially just putting in their own prior knowledge because the data doesn't exist in there, right? what we can actually do towards this counterfactual of what you could have done in a different reality is a very, very difficult question to answer, I think, and doesn't exist to quite a large degree. But it should be the number one question. And I think the most telling part of this is that seminal work by Dave Smith on the sticky situation, where he showed how many countries eliminated malaria, and then despite having importations coming in, did not see a resurgence, and despite the vector being there. This is exactly your point, Silas, right? If you create enough infrastructure and healthcare facility, at a certain point, malaria elimination becomes both permanent and relatively easy. And how do you get to that point without using patches, but by improvement of the common being? And I don't know the answer to that. I know from a modeling viewpoint, to answer your question, it's excessively challenging. And I personally would not think it possible given the current data, right? Modeling can only be as good as what you put in.
Right, yeah. No, thank you guys so much for that discussion. I wish we had Samson here because we were gonna ask him to jump into that point. But we're going to move now. We have quite some discussion to do with Gerardin as well, and we do hope, Samir and Lucy, that you can chip into this discussion as well. I'm still hopeful that Samson will join us, but apparently Zoom still has some problem. If anybody has any feedback from that side, please do let us know. But this has been an incredibly useful discussion to this point, and it's going to hopefully for the next for the remaining amount of time continue to be as interesting. So thank you guys for staying on the line. And we are checking also the chat box. If you have any additional questions or suggestions, please post them there. And would like to have also, if you want to make a contribution such as Silas has made, a lot of these are very enriching to the masterclass. So before we ask Gerardin the question, I want to just skip real quickly to this slide here. This is the slide on the left is from Woolhouse. Lucy, what's Woolhouse's first name? Was it George? George Woolhouse? On heterogeneities of infectious disease. Some clear demonstration here that we don't have even distribution of disease. And Gerardin, you I don't know how to pronounce your first name. Gerardin, I think is fine. You and colleagues focus a lot on, or have focused a lot on identification of individuals who are, harboring these infections, and assessing how certain interventions could be focused on these groups of people and be scaled up to achieve impact. And I would like us to begin the conversation using some of the work that has been done in Zambia here on MDA. So here's one case where mass drug administration used together with other things demonstrated very good impact in low transmission settings, not as much in high transmission settings, but clearly very good impact, very high impact in low transmission settings. Thank you, Joe, for the additional info on Mark Woolhouse. So in Zambia as well, Gerardin, you guys have done some modeling work there, and to try and figure out how can you identify the people who have this last remaining infections. And this is a major challenge because according to the WHO guidelines, for us to be able to implement these MDAs, you must be able to identify, you must make a very good decision on who to give the medicines. You don't want to do over treatment. You also don't want to, waste your medicine. You also don't want to kind of hit on the wrong spot. Do you think, Gerardin, from a general perspective, before we go into the details, that there is a clear picture now on what is the best strategy to identify in low transmission settings the people with the infections? Is there a strategy that would be recommended as the best strategy for identifying these people?
I think for us, we thought that first you start with who is coming into your passive surveillance, who's coming in for symptomatic malaria, kind of the most obvious people to be infected. And then you kind of look out in rings from them, whether you think about, am I in an epidemiological situation where it makes sense that there might be a cluster of infections in their household, or am I in a situation where I think this is occupational exposure, in which case I would check at the occupational level, so people who work with them or people who work in the same place. I think there's no, I think we all know this, there's no one size fits all strategy, and especially as you go down the transmission spectrum, both the case that in lower transmission, you're not doing the same things as higher transmission, but also different low transmission sites can be so different. So I think you just really need to understand your local context and be like, is this the place where, historically we've had a lot of kind of local transmission, and then we've only recently entered into a low transmission near elimination situation. So there might be some vectors just hanging around near the household, or is this a case where like we really think this is, occupational? Someone came into our clinic with malaria, but we know that they just came back from, fishing by Lake Kariba, and we think that that's probably what's going on, in which case maybe we don't waste our energy to check their household, but we, alert the people who are in the facilities closer to the lake that, we've had this imported case, and can you do a case investigation down there and figure out what's going on?
On that, let me just interrupt you a little bit. Last week we had a brilliant class with Christian Langela, and one of the things that was mentioned tangentially was this work. I'm going to skip one slide just to bring that forth. Was this work by this paper written a long time ago by Joe Bremen. I think the title was "The Ears of the Elephant." You must have seen this. And the argument then was that the people who end up in the health facility in your passive surveillance is a very, very small proportion of the entire case. So if we were to go by what you just said, how useful is that for an intervention that we're just relying on that? Don't we need to do more?
Depends on what your goal is, If your goal is just to make sure that everyone who is sick gets prompt and effective treatment as soon as possible, gets cured, moves on with their lives, then yeah, that's perhaps, not just hospital, but also dispensary level. But if you're really going for elimination, then again, you need to think about like, what is the risk that someone with asymptomatic transmission would transmit it to someone else? Because if they're living in great housing, that there's, strong environmental management, no habitats, they're spending their entire day indoors with AC, screened, everything, then, like, maybe that's it. You just don't worry too much. But yeah, if that's not the case, if you think there's, substantial risk of transmission, that vectors are present, then perhaps you take a different approach. But again, it's like, what is your goal? Are you trying to eliminate? Are you trying to very strongly manage your burden? You would do different things.
In one case where I think the aim was to eliminate, we discussed the elimination case, you've kind of concluded that some form of serosurveillance together with MDA would work. Is that something you see across settings?
Well, sure. I mean, I think it's a case of that if you have unlimited resources and you think that the population would be willing to go through this entire very intense experience, then we know it's possible. We know like if you could do anything, you could totally do it. It's a question of like resources. It's a question of acceptability. it's a question of, like, do you want to spend your time and money doing this, or do you have other priorities that are more urgent?
Yeah, we're going to try and tie this to mapping for national and sub-national stratification. So if you don't mind, we would like to do that. Before we do that, I mean, there was this publication from Uganda 2 weeks ago that kind of emphasized the point about the age shift. And earlier we were discussing 2 to 10-year-olds. Here you see a lot of school-age children. Now, Yalin, you've worked with the collaborators in both high transmission settings in places like Nigeria, Burkina Faso, but also with collaborators in low transmission settings. What I would like to hear from you is whether you think you see this pattern repeating itself across the settings, or if it's something that we see only in places with low transmission.
I think it's something that you'll see in places that are experiencing a very rapid decline in transmission. So here in Uganda, it was very high transmission. Then there was extremely effective IRS. And then this is kind of what's happening now. And so you've got what we would think about in our models as an imbalance in the amount of exposure that people are now getting and the amount of immunity that the population has. Because, if your exposure goes away very fast, your population is still going to have some immunity. And the way that these things interact, and along with the third point of the triangle, like symptoms and case management, is complicated. And it's something that we try to understand mathematically using the mechanistic models. Like, if you push down this side of the triangle, what would happen to the other ones? And I think, first of all, from the modeling standpoint, I think that there is still a lot of basic science about immunity and symptomology that is not, incorporated into the models. Some because we haven't quite understood how to do that, and others because I think it's just unknown. Anything that comes out of the models on this question is I would say, like, one has to keep that in mind when looking at those results. But I think this for me is, I think, not too surprising that in a place where you really suddenly decrease the exposure, that there's a group of children who have some remaining immunity from perhaps like their previous years with a somewhat higher exposure, that are still getting some of the small remaining exposure, perhaps because they have less protection. I don't know if bed nets are even like considered to be doing anything in this setting, but we know that adolescents and school children are sometimes the lowest priority people to be using a bed net. So maybe any remaining exposure tends to fall on them. And then because their immunity, while like kind of present, is also not as strong as an adult, that means that any infection they do have are slightly higher density, more gametocyte production, more infectious. And then now you've got this situation where perhaps they are like the primary contributors to transmission because they have more gametocytes and then perhaps less protection from biting. So I suspect that this pattern is something that will continue. I think it will, and I think it'll pop up in other places. I think it may end up looking a little bit differently in different settings. So one thing that I am somewhat curious about is places that have been doing SMC for a while. They've been doing, regular protection of the under 5s. And then once you have your 5th birthday, then what happens to you? What happens to you both kind of clinically, but also what happens to you in terms of transmission? And should these children be particularly targeted in terms of like making sure they have good access to healthcare, making sure that they have access to personal protection, community protection, etc.
One thing,
so you guys, go ahead, Lucy. Yeah.
I was just going to say one thing that we haven't discussed is vector ecology. So in in this particular location, this is Tororo in eastern Uganda, IRS has been so incredibly effective that there's been a shift in species compositions. It's now 99% Arabiensis. So transmission is changing in terms of sort of the focus of transmission, I think, much more outdoors. So presumably school-age children may be, you know, slightly higher exposure in that setting. And I think it's just important to be thinking about what's driven down transmission. If it's intensive vector control, there may be changes in the vector dynamics. If it's something like SMC, then there may not be. And that all feeds into the pattern of across the age groups as well.
Yeah. A follow-up question here and here, of course, we will ask this to Gerardin too, but Samia and Lucy, you guys can jump in as well. A follow-up question here is, Gerardin, from your group, there is kind of some theme here where you have these individual-based models trying to really identify the sources and things. If you were to put this information for purposes of stratification, for decision making by an NMCP, the data that we have from Uganda, for example, how would that play in? How would that influence the subnational stratification? Or should we keep that primarily based on geography? Or how do we bring this demographic data into it?
You mean demographic data in terms of who is transmitting, or?
Correct. So a lot of the stratification is being done on geographic scale, like, this place has high transmission, this place has low transmission. But then now you also have this other dimension where certain age groups are more impacted than others. So how does this play into that decision making?
Yeah, that's a really good question. And I think most of the stratification that I've had experience with has been in the high burden countries. And the goal in high burden countries is to reduce death and illness. And so they're interested primarily in doing that, not necessarily in a more abstract concept of transmission. So if we hypothetically had a situation where school-age children were contributing a lot to transmission, but they were not experiencing a lot of illness and mortality compared to, say, under fives, you're going to have a situation where the program is still primarily considered interested in reducing, mortality in the youngest children. And once their resources are put there, is there enough left to consider, well, we've got something left over, where could we put this to have the largest impact on transmission? Should we target 5 to 10-year-olds for transmission reasons? And I think that's a conversation that is not happening yet, perhaps in the future. But the conversation that I am hearing is that, we're doing a good job or adequate job protecting under fives with SMC. Should we be protecting 5 to 10s for reasons of morbidity and mortality?
Thank you. Thank you very much. Shayla, please. You're muted, Shayla.
Oh, sorry, Fred. Thank you. I think this question goes to all of the three of you. I think you've been using data from surveys and looking at the household survey indicators for malaria control. What are some of the indicators for malaria control that we should be looking at? Are there any limitations with some of the indicators that we look at? Are there indicators that we feel are most important and should be looked at? We could start with you, Samir, or I see Gerardin is unmuted.
Yeah, we one of the people in our group recently put an opinion piece in Malaria Journal talking about DHS and all the things that we would love to see in there. I think from our perspective, a few different things, specifically around the DHS surveys. One is it would be great to see parasite prevalence measured not just in children under 5, especially as this group becomes better and better protected in some contexts, or as transmission is going down, there's less infection in the under 5s and more infection in the older people. And it's hard to see that if you're just looking in the under 5s. Secondly, I think better understanding of treatment seeking would be so incredibly helpful. Both to identify gaps in the healthcare system for improvement, but secondly, to enable us to better understand what routine data is and isn't reporting. And then the third largest gap that we would love to understand more about is actually coverage of SMC, and that the data that is currently kind of collected around SMC, which is the number of doses that are given out in each district, it's really difficult to interpret that because there's uncertainty in the denominators of the targeted population. And then there's also uncertainty in who exactly went into the numerator. If I were a parent living in an SMC eligible, place, and I had a child who was over 5, I might say, yes, my child is definitely under 5, like, please give her SMC, so which is a completely sensible decision for parents to make, but then leads to the programmatic data and understanding what exactly SMC is doing, makes that very challenging. And if we want to understand why SMC isn't having as much impact as we want, then we need to know that better. So for me, I think those perhaps the largest 3 things that I would love to see improvement in these or added to these large household surveys.
Yeah, thank you, Jalin. Samir?
Yeah, I mean, and I should say that because I work closely with the DHS, specifically with Ben Mayala in the DHS. I think that to start off with the main advantages, the DHS was a game changer, right? When you look back at how we were collecting parasites rate surveys, the number of indicators that DHS goes over, the cost of these surveys, is truly a game changer. It informs so many aspects of health in Africa and has countless uses towards science. And I think it's absolutely fantastic. Of course, I would want more indicators. I want the surveys to be bigger. I think the biggest limitation of DHS surveys, the really big limitation, is that they're so expensive and you can't do them constantly in time. And this is, if we want to see what's happening in time, it doesn't have the same temporal information that routine surveillance does. And this is the big limitation that DHS surveys have. The second one is, of course, the sample size. You always want more people sampled to get a better indication of what's going on. But in general, I think the DHS is a pillar. It's a pillar which everyone rests on in terms of understanding malaria prevalence and with regards to other diseases as well. And I think Lucy probably has more comments on this because Lucy probably knows the DHS data better than most, I think.
Yeah, Lucy, would you like to add on?
Yeah, I think Sam has put it very nicely. It's an incredibly valuable resource and one that is open for us all to access and use. And I think that's something really to be celebrated. I think it's difficult adding in new indicators with each round because ultimately people get bored when they're sitting there being asked questions. It can't go on and on. If I could choose a couple of things that I would love to see some more questions around housing, just because I have a personal interest in that. So it's house screening, what kind of eaves houses have. But yeah, I think those would be the two main things. But just I suppose on the disadvantages, the limitations with this kind of data and more generally thinking about meta-analyses where you're looking at the big picture stuff, I think that it's just really important to remember that it's only one side of the story, and all of this needs to be complemented with studies done in specific locations to really understand what's going on in a particular context, because as we all know, malaria is highly localized, variable dynamics, and we need to sort of hang on to that local knowledge and understanding as much as possible. These meta-analyses are very good for pulling out the large-scale trends, and then we complement that with other studies.
Yeah, thanks, Lucy. Fred, back to you.
It's rather unfortunate that my friend Samson Kiware is not here. It would have been brilliant to really have the conversation with him. Shall I just continue, please?
Yeah, thank you. So there's this review that has been conducted on BedNet access, usage, and retention. And so the data seems to imply that the net access plateaus after a while. The data also indicates that the 1.8 per person calculation that is used to determine the quantity of nets that should be distributed is probably not sufficient. Samir, would you like to comment on this?
Yeah, I mean, so this relationship actually was found by us originally in our 2015 eLife paper, and really wonderful work done with Amelia recently on this. The first point to note is that people who have access to nets use nets. This is overwhelmingly true. I mean, you hear anecdotal evidence of people saying that they use them for fishing and this other stuff. It's just not true. People who have access to nets use nets. Now, once you take that one factor into account, that on average on a population level this is true, the very worrying fact is that when you keep pumping nets into a country, you don't necessarily improve access. You get severe diminishing rates of return. And this has been a theme that we've been talking about the entire time. And I don't think I've heard anyone on this call say this. So I don't know who's actually saying that nets can take us all the way, because it just doesn't.
Yeah, Samir, yeah. Sorry to interrupt you with this, but the GTS Pillar 1 has this statement that we've got to scale up core tools. And so we keep saying we've got to keep going, but obviously at some point the incremental cost, the incremental cost effectiveness is not that great. So at what point do you stop scaling, putting money on nets and putting it on something else? I
mean, the devil's in the details, right? They need in distribution of these nets such that they're reaching people who don't have access to them and not people who already have access to them, is of course a good way to spend money. And a lot of this links together with what's being said in the chat box entirely about infrastructure and other permanent changes that can help facilitate this. So yeah, I agree completely. I think it's a misnomer to look at the African situation in this one plot or the one plots and think of it as one situation. In Mozambique, you have huge amounts of resistance. In other places, you have a gap between access and use, such as northern Nigeria. In other areas, you don't have access. So I think, using a one-word statement saying we need more nets, we need no nets, we need no nets, it's not necessarily helpful anymore because there's so much heterogeneity that underlies this. And discussions of these heterogeneities are incredibly important. So if we're going to focus on nets and talk about needing more nets, fine, but we also need to account for the fact that there's a ton of heterogeneities. And one of them is shown in this plot, and it's damning, it's very important, and it needs to be addressed because it's just wishful thinking to just throw money and keep throwing in more nets and expect situations to improve without expanding other core tools, as you call it, or improving the efficiency of these distributions by other means. And this is really important, really, really important.
Yeah, thanks, Samir. So if I were working at the malaria control program, like what is the most important take-home message for me from this particular paper?
The most important take-home message is, well, there's two. We're not there yet with nets in general. So there is still a need for advocacy, at least to continue or to keep it up. And the second take-home message, which is more important of it, is that even just nets alone, the picture is quite complicated and changes country by country, right? It isn't just sufficient to keep pumping nets into a country. We need to look at distributions. We need to look at who has access to nets. We need to look at the relative gain, right? This question of investment, right? Once you get to 70%, going to 75% nets requires a large number more nets than just 5% because of this relationship. Could that money be spent elsewhere on other tools? But we first need to get to 70 everywhere to some degree, for example, or 60, or whatever your number is that you want. So those are the take-home messages, and it's not very helpful for me to give a take-home message, which is essentially 5 different things. But this is the truth of the matter, that we can't talk in terms of simplicities and binary, more nets are better, less nets are bad. It needs to be a multifaceted discussion with sensible balances, a sensible discussion. And I think this maybe is the core message of the paper, maybe. Let's have it that.
No, that complexity is obvious on this grid that you guys have here. Oh, sorry, slides are misbehaving. Attrition rates very different. Some countries, nets are not being retained for that long. In some countries, good. Retention rates seem to be quite varied as well. So,
yeah, that's right.
Yeah.
And just to note, I think Susan, who's also at MAP, is on the call, so maybe she has some things to add on this net stuff. I think she's an author on this paper as well.
Cool. Yeah.
Yeah. So
Welcome.
Susan, please do put a speak up or something if you have anything to add.
Yeah.
But yeah, I mean, this plot shows the heterogeneities nicely, just in terms of retention times, right? And that's just one facet of this all.
Right. Sheila, back to you. Shall I put that up?
Yeah. So, yeah. Thank you, Fred. So this is, I think, one of the main conclusions in that specific paper, that shifting away from mandates of universal coverage is probably what is recommended. What are your comments on this, Samir?
I mean, this was very much, we discussed this sentence at length, and yeah, I mean, I completely wholeheartedly agree with it. It's that realization that nets, and it's been for many years now, that nets aren't going to get us all the way to the problem. It's too difficult for just having nets in that. In the same way that mass drug administration alone won't do it. We need nuanced subnational approaches. This is the way forward, both to achieve the goals, but also financially, this is the most efficient way to do it.
Thank you. And Fred, I think
Yes.
we didn't have any examples on indoor residual spraying. I wonder if our panelists have any comments at all.
Before we do that, I just have one quick question for. I think we could craft one of the issues with the RRS. But before that, if you don't mind, I just have one quick question to Geraldin. Is that okay, Sheila?
Yes, that's fine.
Yes. So before we leave this here, before we started talking about the nets, Geraldin was describing how this survey data can be used and the quality of that evidence, and describing earlier also how some of this information can be used for stratification. And Geraldin, I know that you're very excited about SMC in particular, and this is very reliant on seasonality. And we wanted you to talk briefly about how seasonality impacts using this example. I'll come back to that, Sheila. But using this example here with Prashant, how seasonality would impact our choices for the interventions. Geraldin.
Hey, my internet blipped, so I only caught the end of your question, which I heard how
Yes.
seasonality impacts our choice of interventions.
Yes, because earlier you were kind of excited about SMC in particular, and this is very much influenced by seasonality. So is there something more that you could say about how this would influence our choice for interventions in different parts of sub-Saharan Africa?
Sure. So I think we think about, I think maybe two major aspects of seasonality. One, how it interacts with kind of short-lived interventions, like SMC being extremely short-lived. If your IRS does not last very long, that's also pretty short-lived, in which case you want to think about when you're doing it and not do it in times where you would have less impact. And perhaps RTSS would,
right.
Provocatively be one of these as well. So just being conscious of when the risk is and when your intervention is being deployed. And I think this is like a basic thing that everyone knows, so very obvious. The second thing is seasonality perhaps is also making just operational deployment of your intervention perhaps more or less challenging, in terms of, if there's a lot of rain, perhaps like your roads are washed out, you can't get there, in which case you would want to think about maybe a longer lasting intervention that you can deploy during the time when it's easier to operationally do that, to make sure that during the high risk season, people are still protected. There's also things about, managing stock if demand is fluctuating. And there's also another aspect of seasonality, which basically someone told me about, so I learned about recently, which is, how the thing is how that treatment seeking and demand for treatment changes with seasonality, and not just because of access issues, but because of things like perception of like, it's malaria season, therefore I think my kid has malaria, or it's not malaria season, therefore I don't think this fever is malaria. And the seasonal demand on like parent time. So during the wet season, if that's also my agricultural season, I have other things to do and my kid is sick, I'll wait until market day to bring my kid into town and get treatment. How does this impact the kind of health outcomes for the kid who is experiencing clinical malaria, and what does that mean for like how I as a program want to think about improving access to treatment, particularly in the wet season, because sometimes delays of 1 or 2 or 3 days can be very detrimental. How can I encourage more prompt treatment during the wet season? Is it through community programs? Is it through something else? Having ACTs just, in every house on the shelf, so if needed, they can be given right away. So I think that's, for me, like a few of the places that we think about considering seasonality and making sure that we have it in our models and to the best of our ability, having it be accurate. Though that is a big challenge.
Yes, Sheila, please. Shall we proceed? We have, dear colleagues, we have just 15 minutes to go, but I think we can use this to cover some of the last remaining bits.
Yeah, thank you, Fred. I think still on the question of, okay.
Did we cover that already, right?
No, I think we didn't cover. We just have probably one question on this. So MIS, DHS, and MICS, as well as DHIS2 data, how can we integrate data from all these data sets, keeping in mind the seasonality questions? Gerardin, would you like to go?
Sure. So in the mathematical model perspective, because we essentially have one model where we try to describe everything, the same model generates a series of outputs that can be matched against the different data sources. So within the same kind of simulated system, you have people wandering around with mosquitoes and infections happening, and you say, well, I'm going to measure prevalence on this day. Then you generate a prevalence that you can compare with DHS or MIS or mix. And then you can also say, well, I'm going to measure clinical cases on a monthly basis, and you generate some output that you can compare to DHIS2. So that's, from the mechanistic model perspective, it's actually fairly straightforward to attempt to use these data sources. Some issues that we run into are issues of spatial scale. So if we want to model at a district level, but MIS, DHS, and mix are all at the province level, then this becomes a little bit of a challenge. DHIS2 with the routine data, we've talked about this already, just understanding like what the routine data is actually reporting. It's some fraction probably of clinical incidents, but not only is there treatment seeking that is affecting your readout, there's also perhaps non-malarial fevers that are, coming into the clinic, getting an RDT test and being reported as confirmed malaria. But in our mechanistic model, are we including that? Maybe yes, maybe no. We're going to make sure that we're comparing the right things. So yeah, I think that's it for me.
Yeah, thank you. I think, Fred, one interesting question that we had was about modeling seasonality, the differences between Plasmodium falciparum and Plasmodium vivax. Samir, this is an example from Madagascar. So what are the differences when modeling this, when you think about, when you're considering Plasmodium vivax? What are the differences in terms of the parameters that are included in the model?
I mean, we change what we know for the epidemiology of it. Like we use a temperature suitability that's, linked to vivax versus falciparum. But I don't think that we do the amount that we should do yet. So I love this paper by Michelle. It was very nice because it's looking at actual seasonal profiles. But what I mean is that we know that these two parasites behave very differently. And we don't account for enough of that biology in our models. It's very much the sort of same approach for both of them in terms of geostatistical modeling, which is fine for now. But I mean, in terms of linking together the interaction between vivax and falciparum and how these two will compete in some elimination settings, this is very challenging.
Yeah, so I think if there are any pointers, especially I think one of the practical or the applicability of this paper was around the timing, the spray timing, IRS timing. So if you were to conduct IRS timing in an area that has PVVAX, then how would this change? You're muted, Samir.
No. Yeah, exactly. These kind of heterogeneities are very difficult to answer right now, right?
Yeah.
Which is because it's how much the efficacy changes, how the dynamics change. I mean, we had a paper recently with my student Charlie in India, where we look at the seasonal dynamics of different vectors alone, right? Leave alone the parasite, and they're radically different seasonal profiles between all of them, which makes it very difficult to just have one broad brushstroke of what you're going to do in a given year, when, under what circumstances. And then now you fold into the parasite and the biology, for which there's still a lot to know. I think there's a lot more to be done here.
Yeah, thank you.
First step. So.
Thank you. Fred, back to you.
Thank you so much, Shayla. At this point, I just want to point out that we had a number of questions planned for our colleague, Dr. Samson Kiware, who is unfortunately unable to join. I'm wondering if Silas is still on the call. Silas, are you still there?
I am here, Fred.
Silas, we're going to put you on the spot to take on some of these questions that we were going to ask Samson. I know you guys work very closely, so please come back on video and do us a favor. And if my colleagues from Tanzania are there, if anyone is able to join, I'm told Zoom has a little bit problem there. But if anybody is anything to join, please do that. It's fine. The first question we had here was really about data. First, I just want to put up a slide here because Samson is doing something incredibly nice in Tanzania. They have set up a program there with funding from the Bill and Melinda Gates Foundation. A very comprehensive program, really, to train young people on different components of modeling, mathematical modeling, software development, machine learning, putting in many different projects together to build this analysis, but also very well integrated with the national malaria control programs in both the mainland Tanzania and Zanzibar. So they're in the process of building this relationship. And we had really just wanted him to describe how this process works and what they aim to achieve in the years ahead, given that at the moment, many countries are still not necessarily having these partnerships with local institutions, or this capacity probably does not exist to the level that it should. And we wanted Samson to talk briefly about the work that they are doing with us in Ifakara. So Silas, I know you are part and parcel of some of these initiatives, and it would be nice if you could jump in for Samson to just describe why this is important for the growth of mathematical modeling and also data use in malaria endemic countries, especially in Africa. Back to you, Silas.
I don't know whether I should say thank you, Fred, because you're really putting me on the spot on something I had zero preparation for. And the only, I think, thing we have in common with Sam is we look alike. But I'm not a modeler, I'm not a mathematician, so I can only give a high level of why we think what Sam's team is trying to do is important. So we know that data capacity is very lacking, particularly at the National Malaria Control Programs. Okay, and also it's not just at the National Malaria Control Program, but if you look at the landscape of the capacities that we have on, say, malaria control in general, the mathematical modeling is really a missing link, or data science in general is something that is not well developed. We don't have enough or a critical mass of Africans working on that. So what Sam is trying to do with the national program is to, first of all, assess what capacity is on the ground in terms of data systems, and also people who are working with data and their capacity, and with the idea really to try and develop that capacity at the national level. So this comes from a bigger picture that we're trying to do with the Pan-African Mosquito Control Association, is to link research institutions, local research institutions with national programs to support the capacity where it doesn't exist. So we do that on vector surveillance, we do that on entomology in general, but also on data science and mathematical modeling. So Sam has been recruiting, or is actually trying to recruit, a number of staff at the National Malaria Control Program level to involve them in an internship program, where he will, or his team will train them on basic data science, mathematical modeling, software development, with the view that each country would ideally have a good data system in place. A national program would have that type of data system with dashboards and all the summaries that they can do. As Sam was saying earlier, Samir, sorry, was saying earlier, to be able to summarize macro data into something they can use for decision making. So I think I will just stop there and only talk about the general picture that Sam is trying to achieve with his team.
Perhaps a more specific question, and also in relation to the work you're doing at Pan-African Mosquito Control Association. One of the challenges, earlier Sheila was asking our experts about data sources. One of the challenges that keeps coming up is how to integrate the entomology data. And for example, the DHIS2 does not have a very good way of integrating entomology data. And I know that this is something that Samson in particular has been very keen on. Would you like to talk a little bit about this?
Yeah, sure. Pleasure. Yeah, so Sam has developed the Mosquito DB, Mosquito Database Management System, that has a lot of features that maybe he can go through when he's around. But what we realized was, as we discussed these with national programs, that we can develop these type of data systems, we needed something that can speak or send data to the DHIS2, which is this platform that all countries are accessing and trying to promote. But it was lacking, in many countries, still lacking entomology data. So what Sam has been doing with countries that request that or that accept our help is to help them build bridges between the data systems they would have and the data system with DHIS2, so that the parameters that are required to go into DHIS2 can be pushed into that system as they develop other parameters that they would need. So Sam is working on that. He's established a link between, or a bridge between, MosquitoDB and DHIS2 to send entomology parameters into the DHIS2 platform. Wherever countries will be adopting MosquitoDB, they would also have that facility, but even countries using different data systems and who need some support, they will be able to support them in developing that type of bridges.
Okay. The last question here, and Silas, you can answer, but then it would also be nice to hear from Samir and Jalene and Lucy, is with regard to stratification. So we've, in our masterclasses, we've had the Tanzania case expressed in many, many different forms. Forgive me for risking that. We've shown this slide many, many times in the different masterclasses, an excellent example of how subnational stratification will work. When we last spoke to Sam, he had started this initiative of micro stratification, where they actually go to much lower levels and do that. And I'm wondering whether any of our experts, what their comments would be on the usefulness of this. One thing that Samson told us last time we spoke to him was that at the moment, they're actually using real data instead of mathematical modeling for this purpose, using the examples from Rufiji, for example. So any comments on the benefits of this much more refined stratification? Is it really useful now? How do we integrate it to the district-based, to the regional stratification? How should it inform interventions going forward? So Silas, you can start, but then it would also be nice to hear from Samir, Lucy, and Jalene.
Yeah, perhaps if you allow, Fred, I could respond with a different example that I've lived and saw working. It's the national program in Rwanda that has maps like these, that they have made the stratification up to the sector level. So they go down province, district, I think health facility, catchment, and then sector level, where they can trace how the malaria incidence and prevalence in some cases has been shifting, and they are acting to it. So they look at the maps. This is based on data, health facility data, and each term, I believe, they look at the maps again. If their thresholds move to a level, then they know what to do. So I think the maps, I didn't comment earlier when they were talking about maps and usefulness. At least in Rwanda, we can see how maps are stimulating decision-making, and they really do see, like they know right now, if you go and tell them, where do you have problems? Where do you want to add more interventions or change interventions? They will tell you sector A, B, C, and they show you on the map. So I think what Sam is trying to achieve is similar, but I will leave the experts to comment on that, or on the usefulness of that type of data. Thanks.
I mean, I think it's great to see, and congratulations to Sam for putting this together. It's obviously a very useful tool. Just one comment on urban areas. I think, you know, we're all aware that there are concerns about potentially increasing transmission in urban areas, particularly secondary urban centres, where there may be less in the way of sort of planning and management of housing, the environment, that kind of thing. And the question of stratification and identification of areas that are at higher risk in urban settings is going to be increasingly important, not only for targeting interventions, but also to understand what's driving transmission in urban areas. It's likely to be highly localized, and I think this kind of approach will help us to build up a picture of you know, the types of environment that are at greater risk of urban malaria transmission, and then to design interventions in urban settings accordingly.
I agree. I think that if you have the data to inform this, and you can operationalize at this scale, absolutely, you should go as fine as you can, because as Lizzie mentioned, especially in urban areas, you can have like even neighborhood level differences in what's going on in the environment and access to services and things like that. I wouldn't build this off a geospatial map, probably, but if you have the primary data,
I think someone was saying they have primary data. That's what they're using for their initial trials. Samir, do you have any comments on this?
No, I just really like it. It's simple. Policymakers can look at this and identify specific regions. Devil is always in the details, so obviously you need to dig in more. But you know, picture says 1,000 words, and I think this is excellent. Actually, I commend Sam for the work on this. It's really.
Do you guys have in general terms? So it's a common challenge, you know, in these discussions is there's just no data, or if it's there, it's not great quality, and then you have this layer of human resource capacity necessary, which is part of the work that Samson and many of you guys here are already doing with collaborators across the endemic countries to try and build this capacity, and we're very grateful for that. Any general comment on how we could much more aggressively move towards, you know, data literacy, if I may use that phrase, to inform malaria control much faster than we are doing now?
I mean, I obviously don't know as much about this as perhaps some other colleagues on this call, so they should speak up. But I think this is part of the infrastructure thing. I think there needs to be development into efficient pipe. This needs to be invested in to get this data processed electronically in a usable form that can go straight to researchers in the way that is done in high-income countries. And until that happens, and the data quality is good, ubiquitous, and everywhere, ultimately we're always going to be in a situation where the data is not there, something needs to be done, a map gets produced, the map misses some things, and we're not going back to the root of why the map is wrong in the first place, which is that the data wasn't there in the first place.
Yeah. Thank you, guys. I think we're coming to the end. It's been a wonderful session. I'm going to roll this just, if you allow me, I'll scroll through this to get back to Shayla. This has been a wonderful discussion for me. I don't know about you. It's unfortunate we didn't have Samson to handle the rest of this, but thank you so much, Silas, for coming in. And yes, Shayla, please.
Yeah, thank you, Fred. Yeah, thank you, Fred. Our panelists, Samir, Jalene, and Lucy, we always like to learn from your personal experiences with regards to how you have managed to move forward in your career. So we will start with Samir. Please just share briefly if you've had any mentors, and probably mention just probably one aspect that you have found most useful from your mentors as you moved ahead in your career.
Yeah, I mean, you know, I think I of course grew up in Kenya, in Nairobi, and I'm very lucky to have been able to be educated in the UK, and I don't take this for granted at all. And more than everything, I'm very, very lucky in terms of the mentors I had, both Simon Hay and Pete Getting. You know, we all know that in academia, just one paper can change a person's career trajectory. And ultimately, you know, this happened early on in my PhD, and then it just continued. So I don't take for granted how much the mentors have influenced my career, and I'm extremely grateful for it. What I think is most useful is to keep one's eye, at least for junior researchers, to keep one's eye on the prize. Academia can be a very difficult field. It can be draining, and you can work too many hours and you can get disillusioned. And I think one needs to retain some sense of enjoyment about what they're doing, and balancing that with trying to get publications out. And it's a difficult line to tread because you either do one or the other and you end up enjoying academia, but then not producing the outputs and being upset further down the line, or the other way around. And so I think if I had to offer one thing that was useful that my mentors taught me was how to strike that balance between getting a paper done and out as an output of the scientific output, understand that science builds upon things incrementally, and retaining some sense of enjoyment on what you do. And to that extent, every Friday I have an afternoon where I just program some interesting paper that I read. It brings me joy. Doesn't contribute at all towards my scientific output, but helps me learn new things.
Awesome. Gerardin, would you like to share?
Sure. I think in my malaria life, my primary biggest mentors and champions have been Philip Welkoff, who now at BMGF, but formerly my boss at IDM, and Noor from WHO. And I think they do two, maybe three primary things. One is that I think they have such an inspirational vision for where they want things to go in terms of world malaria and how they want to get there in a, ethical and just way. And that is something that I try to keep in mind myself in my own work. Like, am I doing something that is actually useful? Am I doing something that is more fun and interesting to me, but not useful to the world? And am I working with collaborators and treating people respectfully and appropriately? The second thing that they both do is really challenge me technically and scientifically to do the best that I can. So pushing for the models to be better, to be more appropriate, asking questions. Like, I just remember Noor a few years ago asking, all these models that make predictions of what's going to happen with these intervention scenarios, have you ever validated them, 3 or 5 years down the line? Like, were you actually right? And we were like, oh man, we never do that. No one ever funds us to do that, but maybe we should do that. So just these kinds of things to really say, is this right? Like, can this be better? Are you serious about putting this in front of a malaria control program? Do better. And I think that is tremendously useful.
Yeah, thank you so much, Gerardin. Lucy?
I agree with everything that's been said. Yes, I've similarly been very fortunate to have some wonderful mentors, primarily Steve Lindsay, James Logan, Chris Drakely. And I think what all of them have in common, they're all wonderful mentors, but kindness and a respect for others, and an acknowledgement that it's not worth getting to the top of your field if in the process you're trampling on others. And I think that's a principle that really is very important, particularly in science. Over the last couple of years, a number of colleagues unfortunately have passed away. And what's really struck me is that their legacy has not been a number of grants, a number of papers. It's been the relationships they've had with other people and the way that they have encouraged and brought on the next generation of scientists. That's what people talk about and remember and celebrate. And I think that all of my mentors have that ability to bring the best out of other people and to do so in a very kind and respectful way.
Yeah, thanks, Lucy. Back to you, Fred.
Lucy, thank you so much. Thanks to everybody. Thank you so much, Samir. Thank you so much, Gerardin. Thank you to Silas, and thank you to you, Sheila. Thanks to everybody joining us today. And we had a few delays earlier. As you've heard, there was a situation with Zoom and YouTube in Tanzania. And as a result, one of our experts was unable to join. We will figure out how to do this. Our next masterclass will be focusing on comparisons, epidemiological comparisons between Africa and Asia. And so we will have presenters from Asia and also from Africa. And hopefully we will have someone from South America. I don't know if Dr. Yasmin Rubio-Palis is still on the call, but we are just about to send you a note because we were hoping that we can get some feedback from South America as well. So we will send out an announcement to that, but really just to say thank you to all who support these classes. As you can see, even though we didn't have our partners from Tanzania today, there was still almost 200 people on the call at the beginning. And 3 hours later, there's still half of you hanging out with us. We apologize for any of the situation, the difficulty we faced, but hopefully next week this will be okay. Again, thank you so much for this, and I would like to hand back to my colleagues to say their last words. Samira, I would like you to give your concluding remarks in Swahili, because you and Silas, if you're still there, it would be nice to hear from you final words as well, and then we can bring it to a close. So we start with Samir, Jalin, Lucy, Silas, and then myself and Sheila would close. So just final words, 2 seconds or 3 seconds, and we close it. Samir, please.
Asante yote. Tutaonana siku ingine. Pigia simu.
Asante sana. Jalin, please.
Thanks everyone for coming, and I encourage everyone not to be too afraid of models and to be very vocal when you spot something that smells weird on the model. Just tell us, we'll fix it, or we will try.
Thanks. Lucy?
Thank you, Fred, Wilson, Sheila. It's been a really interesting discussion, and anyone on the call who would like to reach out, drop me an email. I'm always happy to discuss these ideas further and would love to do that. Thank you.
Thank you. Silas?
Yeah, thanks very much for the ride. I was not supposed to be on this, but great topic. Nice to be with smart people and hearing about mathematical modeling. And thanks very much everyone who participated on the chat.
Thank you. And from my end as well, thank you very much. And I hand over now to my colleague Sheila to close.
Yeah, thank you, Fred. Thank you very much to our experts today, Samir, Jalin, Lucy, and Silas. This was a very wonderful and informative masterclass. Even though we were talking models and maps, you still managed to make them the masterclass appealing and informative, and it was actually quite engaging. And thanks to our participants for joining and for keeping the chat box engaged and quite active. We hope to see you again during the next masterclass. Thank you.
Thank you. Thank you all. Thank you so much. Have a good time.